Hello, and a very warm welcome to this podcast in our Psychiatry series. This is a podcast on eating disorders. There are several disorders that come under this blanket term of eating disorders, but certainly the major ones which shall be discussed in this podcast are anorexia nervosa and bulimia nervosa. The other disorders are known as eating disorders not otherwise specified and include conditions such as binge eating associated with psychological disturbance and psychogenic vomiting. There are several overlapping factors between anorexia and bulimia, and it is important to note these. For this reason, we shall discuss the similar and different aspects of both conditions together. Eating disorders are generally conditions that affect young, adult Caucasian females, usually of a higher social class and above average intelligence and achievement. However, it is now certainly being seen in females of other ethnicities living in similar environments, and the incidence is increasing in westernizing cultures such as Japan and India. The average age of onset for anorexia is 18. For bulimia, it is slightly higher at around 20 or 21. The incidence for both conditions is roughly about 4%. As already alluded to, anorexia is predominantly a disorder of the female sex, with 10 times more females affected than males. For bulimia, the figure is similar. The ICD-10 criteria for anorexia nervosa are quite specific and essentially involve self-induced weight loss resulting in a BMI of less than 17.5 or in younger patients less than 85% of the expected weight. It is worth noting, however, that someone with rapid weight loss and the other symptoms of anorexia will often be diagnosed with anorexia before their weight reaches this particular level. The weight loss in anorexia must be self-induced for the diagnosis, and methods of this can be divided into restrictive and purgative. Restriction involves restricting intake and using appetite suppressants, while purging includes things such as self-induced vomiting, using excessive laxatives, and taking excess exercise. Other methods that anorexics may use to lose weight include taking various medications such as thyroxine, diuretics, or in the case of anorexics with diabetes, they may stop taking their insulin. Other key criteria for a diagnosis of anorexia include a morbid fear of fatness, which is described as an overvalued idea, but in some cases can become a delusion. A self-set low weight threshold is where the patient sets a low weight to achieve, which is well below a healthy low weight, falling below the BMI underweight category of 17.5. Endocrine disturbances are also part of the criteria, such as amenorrhea in women and loss of sexual desire and low potency in men. In prepubertal girls, there may be delayed onset of puberty. Other physical features that you should be aware of include anemia, dehydration, muscle wasting, poor peripheral circulation, the presence of lanugo hair, and sleep disturbance. For bulimia nervosa, there are two different aspects to the disorder, a binging element and a purging element. The purging element is seen as a type of compensatory behavior. Binging involves preoccupation with food and cravings, which can often result in a loss of control. This leads to eating an abnormal amount in a short period of time. Typically, following this binge, the patient may then feel guilty and ashamed and engages in compensatory behaviors, including purging and restricting. Purging includes self-induced vomiting, use of laxatives, and excessive exercise, while restriction includes periods of self-set starvation and the use of appetite suppressants. As with anorexia, patients with bulimia frequently also have morbid fears of fatness. There are a couple of other important things to note about these conditions. Minimization of seriousness is something to look out for in eating disorders. This is basically where the patient brushes off the seriousness of their disorder and appears unconcerned about their weight loss. This is in contrast to someone who is unintentionally losing weight, who would express some concern as their weight continues to drop. Commonly, there are also mood changes associated with anorexia. Initially, there may be an elevated mood as the patient achieves the ability to control their weight. Later, however, as the weight decreases, a low mood tends to occur. Importantly, though, low mood is also associated with bulimia. Bulimia, interestingly enough, is not typically associated with weight loss, and if the patient exhibits binging and purging behaviours with weight loss, according to the ICD-10 criteria, this patient should be diagnosed with anorexia. Also note that bulimic symptoms occur in up to 16% of anorectic patients. A way to distinguish between restrictors in both categories is by their attitude to hunger. Restricting in anorexia often leads to feeling good about being able to resist hunger. It is associated with a feeling of control and mastery. Restricting in bulimia, on the other hand, results in hunger, which is associated with irritability and restlessness. Due to the physical symptoms associated with the disorders, the differential diagnosis includes both psychiatric and physical conditions. Psychiatric conditions to rule out, and it must be noted that these often coexist, include depression, obsessive-compulsive disorder, and personality disorders, particularly the anancastic personality disorder. Important physical conditions that may mask as anorexia include neoplasms, particularly of the brain, thyroid disease, and various malabsorption syndromes. The main aims of management are to achieve a healthy approach to food, to patients' weight and eating. And in the case of anorexia, the most important thing is weight gain. For bulimia, 2 treatments have been shown with strong evidence base. These are SSRIs, such as fluoxetine, and cognitive behavioural therapy to break the binging-purging cycle. Management for anorexia nervosa is multifactorial and does not have such a strong evidence base like bulimia does. Weight gain is naturally very important and is introduced slowly, beginning with soft milky foods, moving on to half portions and then full portions, consisting of 3,500 calories a day in 3 main meals and 3 snacks. Patients may be admitted for inpatient care for several reasons, including a very low BMI, metabolic complications of anorexia such as hypokalemia or very low blood pressure. Comorbid depression or risk of suicide will also result in admission, as will failure of other outpatient treatment plans. Therapy for anorexics involves individual therapy, group therapy, and pharmacotherapy. All 3 types of individual therapy are used, so that's psychoanalytical psychotherapy, CBT, and interpersonal therapy, each of which may or may not work for individual patients. In this way, specific therapies are adopted for a given patient and their needs. Group therapy essentially involves family therapy and group psychotherapy. Pharmacotherapy includes SSRIs, but these work to a much lesser extent than in bulimia. For patients who have anxiety associated with food and eating, sometimes low doses of olanzapine may be used. It is also important to medically support anorexic patients by giving them sometimes fluids, vitamins, calcium, and potassium supplements. The overall prognosis of anorexia nervosa isn't too great. 1/5 of patients make a full recovery, 1/5 remain at a severe level, and the remainder have residual symptoms or may in fact relapse. The 5-year mortality for anorexia nervosa is 5%, 2/3 of these due to the effects of starvation and the remainder due to suicide. The fact that so many die due to suicide highlights the importance of management in focusing not only on weight gain but also through addressing any other depression or anxiety symptoms. So that's it for this podcast. Thanks for listening and see you soon.